Okay, so welcome everyone to the sixth lecture of Endocrinology by Dr. Khalid, Step 1 for the new batch of students. Thank you so much for joining the lecture. Hope you guys are doing well. If you guys can hear my voice, can I get a yes in the chat box, please? Thank you so much for joining the lecture. We apologize for starting the lecture a little bit later than our regular schedule due to some unavoidable circumstances. But hopefully it will not affect our schedule for today. That is our goal to finish endocrinology pharmacology, which we will start in a minute. Before we start with endocrine pharmacology, can we do a quick revision and recapitulation of some of the topics from yesterday? Yes or no? Okay, is everyone ready for a quick revision and recapitulation of the topics from yesterday? Oh. Okay, so you have a child who comes to your clinic with your movement of abnormal movements of the hands and feet, along with the eyes, with a firm irregular mass in the abdomen that crosses the midline. What is your professional diagnosis? Okay. Which amplification of which gene is responsible for the development of a neuroblastoma? Very good, NMYC. When we do histology of neuroblastoma, what do we find? Homocyte rosettes, very good. When we see homocyte rosettes, this reminds us that there's another type of a childhood brain tumor where we can see homocyte pseudorosettes. That's a very good medulloblastoma. Okay. You have another patient who comes to you with signs and symptoms of anxiety, tremor, palpitation, pallor, perspiration. What is your diagnosis for this patient? Anxiety, tremor, palpitation, pallor, perspiration. And okay, so the first thing you'll suspect that the patient is in a sympathetic mode. So basically what we would do is, since all of a sudden the patient has anxiety, and along with all of this, the patient has pallor and everything else, we would try to think about pheochromocytoma. So whenever we talk about pheochromocytoma, a constellation of endocrinological diseases comes to our mind. That is multiple endocrine neoplasia. So first and foremost, multiple endocrine neoplasias, are they autosomal dominant or autosomal recessive? Very good. They are all autosomal dominant. Okay. You have a patient who comes to you with signs and symptoms of early morning headache, vomiting, nausea. Patient has abdominal pain, polyuria, renal stones, history of renal stones, and also the patient has anxiety, tremor, palpitation, pallor. What is your diagnosis? MEN1. You have another patient who comes to you with an anterior midline neck swelling. The patient, along with this, has the same symptoms of anxiety, tremor, and also the patient has abdominal pain, renal stones, polyuria, but the patient does not have bilateral temporal hemianopsia, early morning headache, and vomiting. The answer is MEM2A. Very good. This is due to the mutation of a gene known as Rett gene. Very good. Pheochromocytomas are common due to the mutation of 3 genes. Can anyone tell me the names of those 3 genes? What are the names of the 3 genes? Rett, VHL, and Rett, VHL, and which one? NF1. Very good. Okay. So, very good. You have another patient who comes to you with history of passing loose stool or diarrhea. The patient does not have any fever. The patient has a history of mild weight loss. Patient has mild dermatitis and DVT, history of DVT. What is the professional diagnosis for this patient? Very good, glucogonoma. Okay, thank you so much. We have another patient who comes to you with signs and symptoms of anxiety, tremor, palpitation, diaphoresis, tachycardia, tachypnea, and you see that the blood glucose level is at the level of 60. What is your diagnosis? Very good. You have another patient who comes to you with watery diarrhea, decreased potassium level, and absence of acid production in the stomach. Very good. This is gastronomy. No, this is VIPoma. Okay. You have another patient who comes to you with, oh, it's a typo. Okay. You have another patient who comes to you with signs and symptoms of severe abdominal pain, along with passing black tarry stool. The patient undergoes gastroduodenal vaginoscopy and sees that the patient has multiple ulcers in the duodenum, jejunum, and ileum. What is your diagnosis for this patient? Very good. This is a gastrinoma, and the syndrome is known as Zollinger-Ellison syndrome. Okay. Yeah, very good. You guys remember most of the topics which we have studied in the last couple of days. Let's see if you remember the topics from the first couple of days. Okay. So from the first couple of days, we talked about the fact how we have a thyroid embryology, anatomy, physiology, and all of those things. Only one question which I want to ask you that is exceptionally high yield from the first couple of lectures which we took is, you have 3 clinical scenarios. Okay, so let me use my blank page over here for the 3 clinical scenarios. Okay, so you have 3 clinical scenarios. Number 1 is you have a young child. Okay, you have a young child who comes to your clinic with her parents. The child is only 3 to 4 months old. It's a male child who comes to you with ambiguous genitalia. Okay, ambiguous genitalia is, it's difficult to tell whether the external genitals in the young child, whether it's at a female or a male genital. So ambiguous genitalia. Along with this, the young child has blood pressure of 130/90. And you see that the potassium level is 3. What is your provisional diagnosis for this patient? (17). Very good. In 17, we have aldosterone, cortisol, and adrenal androgens. What would happen to the level of aldosterone? Back answers, please. What would happen to the level of cortisol? Okay, so we have highs, lows, highs, lows. Which one is it? The answer is, this is either normal or decreased. Okay. Why? Once again, because pregnenolone and progesterone has to be converted to 17-hydroxyprogesterone and 17-hydroxypregnenolone with the help of 17-alpha. So whenever 17-alpha is not there, cortisol level will fall. Adrenal androgens will also decrease, as simple as that. You have another patient who comes to you with excessive virilization. The patient has an early development. It's a male patient who has early penile development. and the patient has early puberty. Okay, so let me just write precocious puberty. Along with this, the patient is hypotensive. And the potassium is at the level of high normal. So let's say the potassium is close to around 4.9. What is your diagnosis for this patient? 31 hydroxyl deficiency. Okay, you have another patient who comes to you with the same sign symptoms of precocious puberty, but this time you see that the potassium level and the blood pressure is normal. What is your professional diagnosis for this patient? Beta hydroxylase deficiency. Okay. Are we absolutely clear about these couple of things and conditions? Yes or no? Okay. Did everyone access the endocrine lecture recording from yesterday? Did everyone access the endocrine lecture recording from yesterday? Yes or no? You did? Okay, good. I'm just still going to give it out over here for anyone who has not received the endocrine lecture recording. It's over here. That's that. And so are the rest of our lectures. We have Usmle Step 1 Endocrinology. All the free lectures are uploaded. The free lectures are for the new batch, lecture 1, 2, 3, 4, 5. And the last lecture that is we are taking for today for endocrinology will also be uploaded. Okay, so that's that. Having said that, are we going to finish endocrinology today, today or not? Last answers, please. Yes or no? Okay. If we finish endocrinology today, can anyone tell me? Let's see how good your intuition is. Can anyone tell me what are we going to do tomorrow? Which topic are we going to start? Let me give you a hint. We will not start a new topic, but we will do something very, very important. Can anyone tell me what that is? CVS? No, we will not start CVS on free lectures. We will do something that's exceptionally high yield. Okay, let me tell you what we will do tomorrow. We will have 20 questions is something that we will do today. Okay, so let me tell you exactly what we will do tomorrow. Tomorrow you have your first small exam. Okay, first exam on endocrinology. How does that sound? Good or not? Good? Very good. Thank you so much. Thank you. Okay, so first exam on endocrinology. What we're going to do is we will have an exam over here. The amount of questions which we will take the exam on, it will be 40 questions. Okay, 40 questions. And exactly, this will be a 1 hour exam. I will be exactly here, right here with you guys. Yeah, it's exactly 1 block. I'll be right here with you guys. And the way that we will take the exam is, since we have the subscription for Amboss, what we're going to do is this. So tomorrow, for example, let's say that we choose, right? Let's say that we choose the 40 questions or whatever. We start the study mode. And this is how we're going to do. So for example, this is how the screen is going to be. You guys will have your pen and paper. You see the block timing over here, right? So this will keep on going, and at exactly 1 minute and 30 seconds, I'll stop or I'll move forward to the next question. Okay, at exactly 1 minute and 30 seconds, after this one, I'll move on to the next question. So this is how we'll keep on moving forward throughout the whole exam. Does that sound clear to everyone? Yes or no? So this way we can see how I mean, this way we can make sure that everyone can sit for the exam at the same time. Okay, so please be prepared accordingly. Please make sure that you study endocrinology today, and make sure that we finish endocrinology before we start the subscription lectures for next week. Okay, so the recording for tomorrow's class will not take place because tomorrow it's an exam day. Okay, so with that being said, since I have awared you guys, now let's begin our regular scheduled class, that is endocrine pharmacology, and let's do our regular 20 questions. Is everyone ready for endocrine pharmacology? Yes or no? And endocrine pharmacology is actually a very interesting topic to study over here. And endocrine pharmacology, when we study endocrine pharmacology, there are a couple of things I will ask you to do, which will make remembering the names of the drugs and everything else really easy. So please bear with me over here. Can I ask you guys one more time if you guys are ready or not? If you guys are ready, can I get a yes in the chat box, please? Okay, so let's begin. First and foremost, whenever we talk about endocrine pharmacology, the number one group of drugs that is exceptionally high yield for your step 1 and step 2 CK are your anti-diabetic drugs. Okay, so that means that you will receive questions about anti-diabetic medications, not only in your step 1, but time and time again in your step 2 CK. So this is one group of drugs after we're done studying. If you guys want, you guys can make your own small notes from first aid in a blank page or in a small piece of paper, and try to keep it or post it on your wall where you sit and study. The reason why I ask you to do this is because today, when we are going to study the names of the drugs, we will try to remember, we will use mnemonics and everything else, but no matter what we do, after 2 or 3 days, there's a huge possibility that out of 100% of this lecture, you'll only remember close to around 45 to 50%. The only way that you can prevent this from happening is if you see the names of the drugs and their mechanism of action. Every day when you sit in front of your table to study, you just have a quick glance on your wall, and you can have a very quick revision of all the names and the mechanism of actions. And I'll tell you exactly how we should do this. So before I do that, let me finish the lecture and I'll tell you what you can do now. First and foremost, anti-diabetic medications are very high yield. So let's talk about this. First of all, let's talk about the 2 types of diabetes that we deal with. First of all, we have type 1 diabetes and type 2 diabetes. Now, we all know that type 1 diabetes is there from a very young age because this is an autoimmune destruction of the pancreatic beta islet cells. Type 2 diabetes takes place later in life due to familial predisposition or due to having an unhealthy lifestyle or suffering from conditions such as metabolic syndrome and that. So in type 1 diabetes, if we choose to treat our patients with anti-diabetic medications, for example, metformin and your GLP1 agonists, SGLT2 inhibitors, DPP4 inhibitors, this will not work because patients do not have the production of insulin at all. So straight away in type 1 diabetes, our drug of choice is insulin because patients, they do not have insulin. And in type 2 diabetes, since the amount of insulin production in the body is normal, but the struggle is in the action of the insulin, in type 2 diabetes, we will try to choose to treat the patients with anti-diabetic medications first. And then if the glycemic control is not controlled properly with the anti-diabetic medications, then we will choose forward to insulin later. Okay, so that's it. Now, let's talk about insulin in 1 second. Before we talk about insulin, I want to talk about the anti-diabetic medications first. Okay, so let's talk about the treatment of type 2 diabetes mellitus first, and then we'll talk about the treatment of type 1 diabetes. So once again, can anyone repeat the information I just gave? In type 2 diabetes, do we start with insulin right away or do we start with anti-diabetic medications first? Fast answers, please. We use anti-diabetic medications first. Now, let's talk about the first anti-diabetic medications that we would like to give to our patients who are diagnosed with type 2 diabetes. That is, the glycemic control is absent, maybe because, let's say, the patient is suffering from metabolic syndrome. Does anyone know what metabolic syndrome is? Have I talked about metabolic syndrome? I guess not. Okay. Does anyone know what metabolic syndrome is? Okay. So metabolic syndrome is basically a constellation of signs and symptoms where patients are prone to develop diabetes. Number one is, for example, in metabolic syndrome, if patients have blood pressure more than 130 by 80 on a regular basis, this is a risk factor. If patients have hyperglycemia, let's say more than 120. If patients have abdominal waist circumference, right? You try to measure your waist circumference when you order pants or everything else. In case of a male, if the waist circumference is more than 40 inches, or in female, if the waist circumference is more than 35 inches, then this is also a risk factor. If, let's say, the triglyceride level in the male or female is more than 150, that's also a risk factor. And another one is if the HDL level in males or females, if it's low, then that's also a risk factor, so high HDL level. So that's, I mean, low HDL levels, my apologies, not high HDL levels. Excuse me, my apologies. Okay, so that's that. If you want, you guys can write this down in your book because they have not mentioned this in the first aid step 1. You might receive questions about this in step 1, but in step 2 CK, you will receive questions about this. So if you want, write this down. So metabolic syndrome, all of these signs symptoms, what they do is that they increase insulin resistance, right? They increase insulin resistance. So first and foremost, if you have a patient who comes to you who's obese, who has an increased waist circumference, the patient is suffering from hyperlipidemia and all of those things, the first group of drugs that we will give to our patients, we call them metformin. Yes, I'm pretty sure everyone has heard of metformin. What is metformin? Metformin is a group of drugs which belongs, metformin belongs to a group of drugs that we call them as biguanides, right? We call them as biguanides. I'll show you the name of biguanides in the book, but you will not receive biguanides in the form of answer options. So I'm going to use metformin over here. So metformin, how does it act, or what is the mechanism of action of metformin? Mechanism of action of metformin is, first and foremost, we have to understand that metformin will not increase or decrease blood glucose level. We call this as a euglycemic agent. Euglycemic agent. The way that I like to think about this is that metformin is like a buffer. For example, how a buffer tries to make sure that the pH is at a normal level at all times. When you prescribe metformin, metformin will also try to make sure that the glycemic control is maintained at a certain level at all times. Now, how will it do this? First and foremost, metformin will decrease the hepatic gluconeogenesis. We know that the liver and we know that the kidney, these are the two organs that conduct gluconeogenesis, and metformin will only act on the liver. Out of 100% of gluconeogenesis that takes place in the body, more than 50% happens in the liver, and the rest happens in the kidneys. And metformin exactly acts on the liver and decreases the number of gluconeogenesis. It cannot act on the renal system. So whenever we have a stressful condition and we have the release of glycemic or hyperglycemic hormones, for example, glucagon, cortisol, and all of those things, and they try to increase the blood glucose level, metformin will act in the liver and decrease gluconeogenesis, and this will prevent hyperglycemia. That's number one. Number two is metformin will also increase glucose uptake. How? Increase glucose uptake, especially in the skeletal muscle and adipose tissue. How? How will metformin do this? Metformin will increase insulin sensitivity. Increase insulin sensitivity, as simple as that. Okay. And metformin, basically, there's another piece of information. That is, metformin will decrease hepatic gluconeogenesis by inhibiting a drug which is known as MGPD. Okay. Mitochondrial glycogen phosphate decarboxylase. But the thing is, you do not need to know the entire abbreviation of the drug, of the enzyme. But if you want, you can still try to remember this. You might receive 1 or 2 questions with this reference, but the majority of the questions do not have this reference. So that's it. Okay. So this is how metformin will try to act, and the metformin will maintain the blood glucose at a certain level at all times. Now let's talk about the side effects. Metformin has a very severe side effect. That is, metformin is highly known to cause lactic acidosis. You have to remember this. Okay? Metformin can cause severe lactic acidosis, especially if we take metformin in a controlled amount every day. That's okay. But if we take excessive amount of metformin, or let's say we have a patient as a patient of psychosis. Let's say we have a young adult who lives with someone who has diabetes, and let's say we have an 18-year-old woman who is living with her mother. The mother has diabetes. The mother has access to metformin. The 18-year-old woman with psychosis, all of a sudden, if she ingests a lot of metformin, then she can present to the ER with life-threatening lactic acidosis. That's the sort of question you receive in your step 1 exam. So lactic acidosis is number 1. Number 2 is that patients can have signs symptoms of vitamin B12 deficiency. Vitamin B12 deficiency. Another thing is metformin. We do not like to prescribe metformin in patients whose creatinine level is very high. Serum creatinine is very high, meaning that metformin is excreted from the body. The metabolites of metformin are excreted from the body to the renal system. So if the renal system is not functioning properly, then we will not try to prescribe metformin. So there's another question which will be structured from over here. That is, you will get a question in your step 1. That is, they'll tell you, or they'll give you a clinical scenario of diabetes, and then they'll ask you, before we prescribe metformin, which of the following tests shall we perform? Over there, you have X-ray, ALT, AST, serum creatinine, and or urea bicarbonate, and or arterial blood gas analysis. Whenever you have the option between arterial blood gas analysis and serum creatinine, the right answer is always serum creatinine. Please remember this. This is a very common mistake which students make. Students think that we should do an arterial blood gas analysis because of the high amount of lactic acidosis which metformin conducts. But keep in mind that metformin in small amount will not cause lactic acidosis. So, but in small amount, it may progress the renal failure if the patient has any. So if you ever get to choose between these two, your answer option with creatinine is always number 1. Are we clear, everyone? Yes or no? Okay. There you go. Metformin is also known to cause a little bit of weight loss, which the patient usually desires. So that's another side effect. We call that side effect as a desired side effect. Okay. Next one. Next one is we have another group of drugs that also increases insulin sensitivity. The way that it does is, first and foremost, this group of drugs, they will first decrease gluconeogenesis. I'm going to tell you how. Gluconeogenesis. Okay, now how do they decrease gluconeogenesis? First and foremost, can anyone tell me for gluconeogenesis, what are the substrates that we need? Last chances, please. Amino acids and lipids, meaning fatty acids, right? So, fatty acids and glycerol. Okay, so gluconeogenesis. So the way that they work is that these group of drugs, they increase the activity of an enzyme called peroxisome proliferating activating receptor gamma. And the way when we activate this receptor, as a result, there's activation of another substance called adiponectin. Now, what is adiponectin? Adiponectin is basically a substrate or an enzyme that prevents or it decreases lipolysis. Okay, this prevents or decreases lipolysis. If we do not have lipolysis, do we have the release of fatty acid and glycerol? No. If we do not have fatty acid or glycerol secretion, then we cannot use this for gluconeogenesis. Okay. That's that. Are we clear? Yes or no? Okay. So if the fatty acid amount is not produced, then we will not get gluconeogenesis. Okay. Now, while we are doing this, while we are prescribing a drug that is preventing lipolysis, are we also indirectly increasing lipid accumulation in the patient? Yes or no? Are we also making sure that the patient can suffer from hyperlipidemia? Yes, because we're giving a drug that will break down that would prevent the breakdown of lipids. So indirectly, we're also increasing the level of lipids. So what are the side effects of this one? If someone is suffering from heart diseases or cardiovascular diseases, will you prescribe this drug to this patient? Yes or no? No, absolutely not. Why? Because they can cause heart failure. Okay, they can cause heart failure. How can they cause heart failure? If there is excessive lipid accumulation, isn't there a possibility that the peripheral blood vessels can have progression of atherosclerosis? Yes or no? The answer is yes. When they have progressions of atherosclerosis, what happens to the lumen volume? Does it increase or does it decrease? The answer is when there's atherosclerosis, the luminal volume will decrease. Very good. As a result, the pressure needed to push the blood through those lumens will be very high. So when the heart tries to push the blood out, right? When the heart tries to push the blood out, the left ventricle, they have to work more to push the blood because of the high amount of afterload which the left ventricle will suffer. As a result, there will be progression of heart failure. So that's that. Another thing is that patients can also have weight gain, yes, because there is lipid accumulations in the body, so patients can have weight gain. Another thing is high amount of fat accumulation is never good for the bones because they disrupt the normal hormonal balance and they decrease the hormones that are responsible for maintaining the integrity of the bones. As a result, patients can suffer from fractures, yes? Okay, so that's that. Are we clear, everyone? Yes or no? Yes, okay, good. What is the name of the drug? Okay. Okay, then what is the name of the drug? Now, the way that you remember the name of the drug is, how many of us have heard the name or have seen this dish? I'm not sure if you guys have seen this or eaten this. Have you guys ever seen or eaten a calzone? Do you guys know what a calzone is? Anyone? Especially this is in Italian. This is an Italian delicacy. I'm not sure if you guys have eaten this. Calzones, right? Calzones are basically contents of pizzas that are folded into this sort of a half moon sort of a pie, right? Calzones. Okay, and that's that. Do you guys want to look at these pictures a bit more, or do you guys want to go back to your lecture? Okay. Yeah, let's go back to our lecture. So this is a calzone. Now, calzones are exceptionally high in cheese and fat and meat and everything else. So what happens when you have high amount of calzone? What happens when you have high amount of calzone? Isn't there a possibility you can get cardiovascular disease, weight gain, and fatty and risk of fracture due to fat accumulations? Yes or no? Yes. Okay. So calzone for all the drugs that ends with zone. meaning calzone or pioglitazone, okay, or rosiglitazone. Okay, so everything that ends with zone will remind you of calzone. Calzone is a fatty food that has the potential risk of causing weight gain, cardiovascular disease, risk of factors, and it's the anti-diabetic drug that rhymes with calzone. Are we clear, everyone? Yes or no? This is how you can remember this. Okay. Very good. Let's move on to the next. Let's move on to the next one. So we talked about the drugs that basically increases your insulin sensitivity. We have another group of drugs. The way that they will work is I'm going to tell you how. Okay, first and foremost, let me draw you a pancreatic beta cell. Okay, this is a pancreatic beta cell. Okay. So as we all know, insulin is responsible for the production of the GLUT receptors, right? Especially it produces GLUT2 and GLUT4. GLUT2, when it is produced, my apologies, GLUT4, when it is produced, GLUT4 is responsible for the uptake of glucose in the pancreatic beta cells, right? So GLUT4. So what happens in the normal pancreas is whenever we have glucose will enter the pancreatic beta cells to the GLUT4, and when it does, it will undergo glycolysis. This glycolysis will result in the release of ADP, right? After glycolysis, the substrates, they enter the TCA cycle. Then from the TCA cycle, what do we get? We get NADs, FADs, right? And those NADs and FADs, they enter the electron transport chain. In the electron transport chain, we have 5 substrates. It goes back and forth, back and forth. And at the level of complex 5 is known as ADP synthase, we get ADP. This is the full breakdown of glycolysis. We will study this in details in biochemistry. But over here, so glucose enters, it enters the glycolytic pathway, TCA cycle, electron transport chain, and releases ADP. This ADP that's released, it will block a channel over here. This channel is called the potassium channels. Potassiums are freely allowed to leave the cell, but when we block the potassium channel, the level of potassium inside the cell will rise, leading to membrane depolarization. As a result, there will be opening of GLUT4 in muscle and adipose tissue, not pancreas. Give me 1 second over here. Is GLUT4 or GLUT? My apologies. Let me see. You're right. My apologies. Okay. Very good. Okay. So where were we? So glucose will enter. Okay. Thank you so much, Dr. Ethan, for helping us out. So this is GLUT2, not GLUT4. Glucose will enter. GLUT4 is for skeletal muscle and adipose tissue, and GLUT2 is for the pancreatic beta cell. Okay. So that's that. Thank you so much. I apologize for my mistake. Now let's move forward. So glucose will enter to the GLUT2, and it will enter the glycolytic pathway, lead to the formation of ATP. ATP will close the potassium channels. It will prevent the release of potassium from inside the cell. This potassium, what they will do is they will cause increased membrane depolarization, and they will open another channel. This channel is known as the calcium channels. Calcium will enter the cell, and when it enters the cell, the intracellular increase of calcium will cause fusion of the vesicles containing insulin, leading to increased release of insulin. Okay. Isn't this a mechanism which we have already discussed in the past? Yes or no? How does insulin, or how is insulin secreted? The answer is yes, right? So we have another group of drugs. What they will do is, along with ATP, these drugs will further increase the power of closing the potassium channel. Okay, these drugs, they will further close the potassium channel and increase membrane depolarization more. So there will be increased entry of calcium and there will be increased release of insulin. Okay, so what are the names of these drugs? Does anyone have any idea what drug this is? This is your sulfonylureas. Okay, so sulfonylureas, that's how they will act. So this is the mechanism of action of sulfonylurea. Okay, so this is how sulfonylurea will act. Now, the question is, let's talk about some questions over here. First and foremost, do we have patients who abuse the possibility of having a hypoglycemic attack? Yes or no? The answer is yes, meaning that we have a psychiatric condition, which we know as factitious disorder, right? Factitious disorder opposed on self, or factitious disorder opposed on someone else, meaning that there are psychiatric conditions where patients abuse certain drugs to get medical attention for an unknown reason. Now, over here, if someone abuses sulfonylurea, will we have only the increased release of insulin or increased release of insulin and C-peptide? Which one? Fast answers, please. We will have, very good. We will have increased release of both insulin, not only insulin. Sulfonylurea is the only group of drugs that will release. Since insulin is being secreted, we know that when insulin is secreted from the pancreatic beta cell, it cannot get secreted by itself. It has to be secreted with C-peptide, right? So if there's anything that is increasing your release of insulin from the pancreatic beta cell, the C-peptide level will also increase. So that is also sulfonylureas are responsible for increasing the release of insulin and C-peptides at the same time. So you will get increase of both of these substances in your blood. Next one is there's another group of drugs that works exactly like sulfonylurea, right? We call those drugs as meglitanides, right? Meglitanides. So these are meglitanides. Now, meglitanides as a whole, they're not very high yield for your exam, meaning that they do not have a lot of questions that will be structured from this. Whenever they try to describe these conditions, the drug of choice for Usmle step 1 is basically sulfonylurea. But meglitanides are your another group of drugs that can also act in the same way and increase the release of insulin and C-peptide. So before we address the names of meglitanides, let's address the names of sulfonylurea first. So sulfonylureas there are two generations of drugs, first generation and second generation, right? The first generation group of drugs, these are C and T, chlorpropamide and tolbutamide and chloropropamide. And the second group of drugs are all your Gs. Gs for glyburide, glipizide, and glibenclamide. Okay. In your first aid step 1, they have mentioned glipizide and glyburide. There's another group of drug. There's another type of sulfonylurea from where questions are structured. It's glibenclamide. Okay, that's also another type of sulfonylurea that can act in the same way. And then again, we have meglitanides. Meglitanides are nataglinide and rapaglinide. You do not have to remember the names of meglitanides because they do not ask you questions from over here. Okay, are we clear, everyone? Yes or no? Okay, very good. Is anyone taking notes of this lecture? Yes, okay. Please do not take notes of this lecture. Just give me 1 second, please. Please do not take notes of this lecture. This is only for your understanding because everything is over here in the first aid book. Okay, so you have to learn from, you have to read from over here. So please try to understand this. Please try to use this to try to understand what's happening in the first aid. Okay, so me one. Okay, Are we ready to start talking about the next one? Okay. Okay. Let's talk about the next one, that is increased insulin secretion. Increased insulin secretion under the influence of glucose. Okay. Now, what is the name of the drug that will increase your insulin secretion without the help of glucose, right? The names of the drugs that increases insulin secretion without the help of glucose is sulfonylurea and meglitanides. If we have increased insulin secretion with the help of glucose, then the names of the drugs which we will talk about are, number one, they belong to GLP agonists and DPP4 inhibitors. Now, one more time, are we supposed to take notes of the blank pages? Yes or no? No. Okay. Are we supposed to have our undivided attention at only the blank page, looking at the lecture and trying to memorize the information right away or remember the information right away? Yes or no? The answer is yes. Okay. Please do not take notes. The only reason why I'm doing this on the blank page is so that when we read the first stage, you guys have completely learned the information from over here. So you do not have to spend extra time in your own time to sort of learn what's happening. Okay. So that's that. Okay, now let's begin with the first one, that is GLP agonists. GLP agonists are excessive, a very, very high yield. GLP stands for glucagon-like polypeptides, right? Glucagon-like polypeptides, GLP1 agonists. Okay, now my next question to you guys is, if we give something in the system that looks like glucagon, right? If we give something in the system that looks like glucagon, will we have excessive release of glucagon from the normal alpha cells of the body? Yes or no? The answer is no. Very good. Okay. So when we give glucagon-like peptide from outside, there will not be release of excessive intracellular alpha cell glucagon. So the normal amount, so let's remove the cross, so decreased glucagon secretion whenever we give GLP-1 agonist. If glucagon is not there, right, what would happen over here? Will the blood glucose try to be on the higher side or on the lower side? Fast answers, please. They will be on the lower side, right? So because glucagon is responsible for increasing your blood glucose. So when glucagon is not there, blood glucose will start to decrease. Another very, very high yield thing over here is whenever we give GLP-1 agonists, they act like glucagon and they decrease the glucagon secretion. But they do another thing, that is, they decrease your peristaltic movement or peristaltic movement of the stomach. That is, they decrease gastric emptying. Okay, so if you have decreased gastric emptying, are you going to be satisfied with a small amount of diet or with a small amount of food? Yes or no? The answer is yes. Okay, so can we use this for patients who have diabetes plus a very high BMI? Yes or no? The answer is yes. Okay, so we can give these group of drugs. Now, how do we remember the names of the drugs? Okay, the way that we can remember the names of the drugs are like this. Okay, so we will think about two things over here. Okay, so we will draw on a mnemonic. Okay, we will draw a mnemonic which will not only help us remember the names of the drugs, it will also help us remember the side effects. Okay, how do we do this? First and foremost, what I want to show you guys is over here, let's say that this is a beach. Okay, so beach, and you have your water body over here, right? So you have your waves over here, okay? And in these waves, you have what? Tides, right? Big tides. Can you tell me who are the type of people who waits for tides? These people are your surfers. Very good. Okay. These people are your surfers. Okay. They are surfing on the tide. Okay. Surfers, do they tend to be obese or fit? Fast answers, please. They tend to be more on the fitter side, right? Because if they're not fit, then they cannot maintain their balance on the surf and then they will fall. So one more second. Over here, you have another surfer who is not that fit, and the surfer has actually, the surfer actually fell, and you see that the surfboard is over here hitting the stomach. Okay, the surfboard hit the stomach, hit the abdominal area of the surfer over here. Now, why am I telling you this? I'm gonna give you the explanation in one quick second. Another thing is, you have another surfer over here who, after surfing, comes to the shore, and due to confusion, the surfer is vomiting. Right? These yellow droplets are supposed to think you of vomit. Okay. Now, the reason why I'm putting so much emphasis on this is because the number of questions that you will receive from GLP-1 agonists are very, very high. So that's why you guys need to remember all the informations over here. First and foremost, tides. Tides will help you remember that GLP-1 agonists, the names of the drugs all ends in tide. So we have exenatide, and we have liraglutide, right? Tides, all the tides. That's number one. Number two, you see the surfers over here, surfers being fit, right? Will help you remember that we give exenatide and liraglutide to decrease gastric emptying and to promote weight loss. Is it clear up to now? Yes or no? Tides and weight loss? Yes. Is it clear or not? Up to now. How we came up with the name tide, and how does this look like? They will have, the patients will have decreased gastric emptying, weight loss? Yes, okay, good. The next thing is, you see the surfer over here who fell while surfing. The surfboard hit the abdominal area. If the surfboard hits the abdominal area, can we use this to sort of remember that patients will have abdominal pain or pancreatitis? Okay, something hitting the abdomen, causing abdominal pain, pancreatitis. And another patient coming to the shore, and another surfer coming to the shore and vomiting for nausea and vomiting. Okay. Are we clear, everyone? Yes or no? Okay. So that's all you need to know about the GLP-1 agonists. Okay, that's that. Next one is, okay, before I move on to the next drug, let's do a quick revision of what we have studied till now. Okay. If I tell you that there is an anti-diabetic medications that we have to give, and before we give that, we need to measure the serum creatinine. What is the name of that drug? Metformin. Very good. If I tell you there's another group of drugs that can cause weight gain and heart failure and risk of fractures, what are the names of those drugs? Very good. Pioglitazone and rosiglitazone. Yes, which rhymes with calzone. If I tell you that there is another group of drugs that will potentially increase the closure of the potassium channels in the pancreatic beta cells, leading to more release of insulin. What are the names of those group of drugs? Sulfonylureas. Okay. Okay. And once again, if I tell you that there's another group of drugs that will decrease the secretion of glucagon and increase gastric emptying, promote weight loss. What are the names of these group of drugs? GLP-1. What are the names of the GLP-1 agonists? Well, what are the names of the GLP-1 agonists? Exenatide and liraglutide. Okay. What are the side effects of exenatide and liraglutide? What are the two side effects? Nausea, vomiting, and pancreatitis. Okay. There you go. Now, whenever we prescribe our patients or whenever we have GLP-1 in the body, GLP-1 is broken down by an enzyme, which we call as, first it states that GLP-1 decreases gastric emptying. Yes, I also state this, the GLP-1 decreases gastric emptying. Okay. Is there a confusion, Dr. McLean? Do we have any confusions? Anyone? Do we have any confusions? Can I move forward? Dr. Teresa McLean, do you have any questions for me? A while ago, you said increase. I said increase gastric emptying. Okay. No, it's decreased gastric emptying. I apologize if I said increase. It's decreased gastric emptying. Okay. Yes, maybe I did. I'm not sure. Okay, but that's it. How osteoporosis is caused by thiazole load. Okay, I'm not really sure which drug you're talking about, but if you're talking about thiazolidinones, okay, or pioglitazones and rosiglitazones, they increase the risk factors. They increase the risk of fractures by increasing the amount of fat accumulations. With the amount of fat, it causes hormonal imbalance. This hormonal imbalance is responsible for causing increased risk of fractures. Once again, GLP-1 agonists, please keep in mind that they decrease gastric emptying, not increase gastric emptying. Okay, and thank you so much for fixing the mistakes. The reason why there's a little bit of mistakes here and there, it's because I'm trying to take the lecture from my own memories and from my own knowledge. Eventually, we'll move forward to the first aid book and we'll move forward. Okay. So the reason why I'm taking the lecture in the blank page is because I just want to give you guys some mnemonics and everything else, so to make sure that you do not forget the information. Okay. So are we clear up to now? Can we move forward? Okay. Now, so we were talking about this thing over here. Glucagon-like polypeptide in the body is broken down by an enzyme. The name of this enzyme is called dipeptidyl polytransferase. Dipeptidyl transferase 4, DPP4. Okay. Now, the thing is, if we give a drug that prevents the action of DPP4, indirectly, are we increasing GLP-1? Yes or no? Okay. So can we think about this? That is, we are breaking down DPP4. Okay, another word of break of this is we are clipping. Clip the DPP4. What happens when you clip or you prevent the DPP4 from acting? Okay, you're not allowing this to act. As a result, GLP-1 increases. So you use clips, right? So with clips, you can remember the mnemonic, that is GLPs. This GLPs for linagliptins, saxagliptins, and sitagliptins. Sitagliptins. Okay, glip, glip, glip. Are we clear? Yes or no? Yes. Okay. So once again, what happens when you prevent DPP4? When you prevent DPP4, you're increasing GLP1. When you increase GLP1, once again, what's happening? You are decreasing the release of glucagon and you are decreasing gastric emptying. As a result, patients can have your maintenance of the blood glucose levels, and that's that. Another one is over here, DPP4. Can it also increase your, or can it also promote weight loss? Yes or no? So the thing is, DPP4, since it increases GLP1, they're supposed to promote weight loss. But the thing is, when we compare GLP1 with DPP4, and I ask you which one will cause more weight loss, the answer is GLP1. GLP1 is more prone to cause weight loss. It's more promotional of causing a weight loss. DPP4 is known to be weight neutral, meaning that it will not promote as much weight loss as GLP1. But what it will do is that both of these two drugs will increase satiety. That is, patients will be satisfied with the amount of food they have. Are we clear, everyone? Yes or no? Okay. So another quick revision and recapitulation before I start the next group of drugs. You have you have a drug that inhibits mitochondrial glycogen phosphorylase decarboxylase and prevents hepatic gluconeogenesis. What is the name of this drug? Metformin. Very good. You have another group of drugs. You have another group of drugs that increases the release of insulin from the pancreatic beta cells by closing the potassium channel and increasing membrane depolarization. What is the name of these drugs? Sulfonylureas. Very good. Okay, you have another group of drugs that will promote weight loss, increase satiety, decrease gastric emptying, and decreasing glucagon release. What is the name of these group of drugs? Well, what are the names of these group of drugs? GLP-1. Which drugs falls under GLP-1? What are the names of the GLP-1s? Okay, very good. Can anyone tell me the side effects of GLP-1s? Side effects. The tide, the surfers, right? We have pancreatitis, nausea, vomiting. Okay, then the next one is DPP4. DPP4, dipeptidyl polytransferase 4. They will prevent the breakdown of GLP-1, increase GLP-1. And what are the names of these DPP4 inhibitors? These are linagliptins. Very good. Okay, so that's it. If we have to compare gliptins with tides, exenatide and liraglutides, which one will cause more weight gain, weight loss? My apologies. Tides. Okay, very good. So we have done everything surrounding the pancreatic beta cell and insulin stimulation and this and that to sort of increase or decrease the level of glucose. Now, the next group of drugs that we will give to our patients, we will try to manipulate the glucose levels in two regions. Number one is we will try to manipulate them in the proximal convoluted tubules of the kidney. Another way that we will try to manipulate the levels of the glucose is by increasing or decreasing the absorption of glucose from the intestines, right? Because these are the two sources from where either we can increase in the kidney, we can either increase the amount of glucose in the urine, and from the intestines, either we can decrease glucose absorption, right? If we have increased glucose release, or let me just rephrase this. Let me say, if we in the kidney, we can do decreased glucose reabsorption, and in the intestines, we can have decreased glucose absorption. In both these cases, are we decreasing the level of glucose in the blood? Yes or no? Yes. Okay. So let's talk about the first one. The first one is in the proximal convoluted tubule. Okay, we'll talk about this in details in the renal system. In the proximal convoluted tubules, we have certain channels. The way that these channels, they work is if we try to have a closer look, okay, if we try to have a closer look on these channels, then we will see some things that are going on. So let's say I sort of magnify the proximal convoluted tubules over here. So what do we see? Let's say that this is a proximal convoluted tubular cell. We know that the proximal convoluted tubules are responsible for the highest amount of reabsorptions. Yes or no? Proximal convoluted tubule, for example, if there is increased amount of release of amino acids, they're reabsorbed. If there's increased amount of release of glucose, they're reabsorbed. If there's increased amount of amino acids, glucose, or any sort of things, for example, bicarbonates, phosphates, or anything else, which is filtered excessively, can be reabsorbed in the proximal convoluted tubule. The way that this works is over here, you have channels. Okay, you have channels. This is the luminal side, meaning that this is where the filtration is happening, and this is the side of the blood. Okay, this will get absorbed into the blood. Now, the way that this works is on the luminal side of the proximal convoluted tubule, you have cotransporters, that is sodium cotransporters, right? Sodium cotransporters. Since we are using the word cotransport, then we can immediately understand that they are using facilitated diffusion by the mechanism of facilitated diffusion to reabsorb anything, for example, glucose or anything else. For right now, let's talk about glucose. That in the proximal convoluted tubule, sodium absorbs glucose with the help of sodium-glucose cotransporter. And whenever glucose enters the proximal convoluted tubular cells, it is reabsorbed into the blood by your sodium glucose antiporter. So they are using primary active transport. This is something which we will talk about in details in the renal system. But for now, just talking about this so we know how this drug works. So now, if I prescribe a drug that is preventing the action of this channel, is glucose being absorbed into the proximal convoluted tubular cells? Yes or no? From the lumen, can we absorb glucose? No. So we're not absorbing glucose through the luminal side because we're blocking the sodium glucose cotransporter. As a result, do we have increased glucose that will be present in the urine? Yes or no? Yes. Yes, we will have high amount of glucosuria. Did everyone understand how we have glucosuria? Okay, good. So that's that. Oh. Now, the thing is, if you have a urine that is high amount of glucose, isn't there a possibility that patients can get easily, that glucose can act as a fertile ground for organisms, so patients can suffer from UTIs? Yes or no? Patients can also suffer from, for example, female patients, they can also suffer from vulvovaginal candidiasis. Yes? Okay. Another thing is, isn't there a possibility that patients can be easily dehydrated? Yes or no? The answer is yes. Another thing is, will you prescribe this patient to someone who has high serum creatinine? No. Okay. So one more addition to the drug. So if anyone asks you, what are the two groups of drugs you will not prescribe to someone with renal insufficiency, especially what are the two anti-diabetic drugs you will not prescribe to a patient who has AKI or CKD? The answer is metformins and sodium glucose cotransporting inhibitors. Yes, these drugs are called, okay, these drugs are called flozins. Are we clear? Yes, these drugs, they're called flozins. Okay, so we have canagliflozins, we have the empagliflozins, we have the dapagliflozins. Whenever we see a drug with the name flozins, try to remember that flozins, they act on the sodium glucose cotransporter. Okay, are we clear? So these drugs are your SGLT2. These channels are SGLT channels. Okay, are we clear, everyone? Yes or no? Can I move on to the next group of drugs? Okay. Okay. Next one is we are preventing the absorption of glucose from the intestines, right? We know that in the intestines, in the intestinal brush borders, we have an enzyme called alpha glucosidase, right? Whenever we have a high carbohydrate diet, they are broken down by the salivary amylase. Then we have the release of pancreatic amylase, right? And then we have the amylases, they sort of break down the carbohydrates, which are polysaccharides. They turn them into disaccharides. Disaccharides are converted into monosaccharides. Disaccharides are broken down into monosaccharides with the help of glucosidase enzymes. And after we have the formation of monosaccharides, right? These monosaccharides, these small molecules, are absorbed through the intestinal brush border. What if I give a drug that prevents the action of these alpha glucosidase? Can the disaccharides be broken down into monosaccharides? The answer is no. If the disaccharides are not broken down into monosaccharides, can they be absorbed properly? The answer is no. As a result, will we have a high amount of glucose that stays in the intestinal lumen? The answer is yes or no. The answer is yes. So if the thing is we have a high amount of carbohydrate that stays behind, especially disaccharides that stays behind in the intestines, isn't there a possibility that these high amount of carbohydrates, they can act as osmotically active substances and they can pull in water, yes or no, into the lumen? If they pull in water into the lumen, the patients, can they have excessive tendency of GI bloating? The answer is yes. Can they have abdominal distensions? The answer is yes. Can they have diarrhea? The answer is yes. Okay. Are we clear? Yes or no? Okay. I'm pretty sure you guys know the names of these drugs. The names of these drugs are called acarbose. Okay. And another one is Meglitol. Meglitol. Okay. Are we clear, everyone? Yes or no? Yes. If yes, then I'll move forward. If no, I'll explain myself one more time. Are we clear or not? Okay. Okay, good. Now, are you guys understanding the lecture? Yes or no? Is everyone understanding the lecture? Thank you so much. Okay. Okay, now, so one more thing over here. You have, I want to talk about the different sorts of insulin in the body. Okay, I want to talk about different sorts of insulin in the body. So the thing is, whenever we talk about insulin, we have certain different types of insulin, right? We have what? We have insulins that have a rapid onset of action. We have insulin that have that act in that act for a short amount of time, right? If they act for a short amount of time, that means that they can be easily broken down in a matter of hours. Then we have another sort of insulin that falls in between the short acting and long acting. And then we have immediately long acting insulin. Okay. So rapid-acting insulins are basically given to sort of make sure that the patient's glycemic control is maintained if the patient has severe hyperglycemia. These are your normal acting. I'm pretty sure if you guys have patients with diabetes in your own family, and you will see that these patients, they have been prescribed the rapid-acting insulin initially if they have to get prescribed for this. Let me ask you a question over here. If you have to prescribe the rapid-acting insulin or the long-acting insulin for patients who just got diagnosed with diabetes a couple of years back and their anti-diabetic medications failed, which one will you prescribe? The rapid-acting insulin or the long-acting insulin? Which one? Which one will you prescribe to your patients? Rapid-acting or long-acting? You will never prescribe long-acting insulin to a patient in the initial stages of treatment of diabetes. If a patient has type 2 diabetes, then first and foremost, you're going to try to maintain their lifestyle. Okay, ask them to have a good lifestyle, eat a healthy diet, sleep on time, avoid glucose-containing products, maintain the weight, and you will prescribe them metformin. If it's not controlled with metformin, then you can try adding another group of drug, anti-diabetic medication. If that doesn't work, then the next step of management is you act. You give rapid-acting insulin. If rapid-acting insulins, if they do not work, then you give them additional long-acting insulins. So that's it. So that's how they work. Now, rapid-acting insulin, the way that they work is if we have over here, if we have the insulin level, right? We have insulin level on the y-axis, right? And over here, if we have the time that takes for the drug to work, so we have 0 to 18 hours. So rapid-acting insulin will work rapidly, right? So can we expect the graph to sort of be like this, that right after you take the drug, the concentration or the insulin concentration increases, and then it rapidly falls? Yes or no? Yes, okay. Then if you take, okay, so let's talk about this. So what are the names of the drugs, the rapid-acting insulin? The rapid-acting insulins, you can remember them by the word LAG. LAG stands for insulin lispro, insulin aspart, insulin glulysin. Lispro, aspart, glulysin. So if you ever get this sort of a picture in your step 1 exam and they show you a graph that looks like this and they ask you, which insulin do you think this belongs to? The answer is either it's insulin lispro or aspart or glulysin, as simple as that. Next one is short-acting insulin. Obviously, if it's a short-acting insulin or regular-acting insulin, the curve will be a bit less steep. It will be something like this, right? It will be something like this. Right? But the question that you will get is about the long-acting insulin, because the long-acting insulin, they will work for a short period of time, meaning that these drugs, they will not peak, no peak. So this is a question in your step 1 exam. Which type of insulin has no peak on an insulin graph? The answer is long-acting insulins. They have no peak on the insulin graphs. Well, what are the names of the long-acting insulin? They are insulin glargine and dedamir. Are we clear? Yes or no? Everyone? Okay. If I have to ask you about the functions of insulin, will insulin convert increased glucose to glycogen? Yes or no? Yes or no? The answer is yes. Okay. Where will they convert this increased glucose to glycogen? In the liver In the kidney, in the heart, in the brain, in the pancreas, where? Where will they have this? Liver, very good. Okay, the liver is the main side of metabolism. Very good. Insulin, will it increase glucose uptake in the skeletal muscle and the adipose tissue, or decrease glucose uptake? They will increase the glucose uptake. Insulin, is it an anabolic hormone or is it a catabolic hormone? Anabolic hormone. So if you're saying insulin is an anabolic hormone, will it increase protein synthesis or decrease protein synthesis? Very good. Will insulin increase triglyceride or decrease triglyceride? Very good. Insulin, will it shift potassium outside of the cell or inside it or into the cell? Very good. So patients who are getting treated for diabetes with insulin, can they get hypokalemic or hyperkalemic? Very good. Okay. Let's begin with our lecture. Okay, diabetes mellitus therapy. All patients with diabetes should receive should receive education on diet, exercise, blood glucose. Okay, so we know these things. These are not questions. I'm going to tell you exactly what the question is. This is a question. Type 1 diabetes, straight up, you have to give insulin first. For type 2, you have to give orals first, and non-insulin injectables, then insulin. Okay, so that's it. Gestational diabetes, you have to give insulin right away. Okay, if nutritional therapy and exercise alone fails, then you have to give insulin. And that's it. Okay, we talked about the insulin preparations right now. So this graph is really important. Insulin can cause hypoglycemia, we all know this, and they can also cause lipodystrophy. What is lipodystrophy? But when we use the insulin pen to insert the insulin in a subcutaneous way, long-term using the same site for administration of the insulin can cause dystrophia of the lipids, meaning that patients can experience pain and discomfort. So it's advisable to change the position of insulin administration from time to time to lipodystrophy. Another one is weight gain, and hypersensitivity is not there. Non-insulin injectables are these drugs. Okay, GLPs, DPP4, these ones. Are we clear? Yes or no? Okay, these drugs, they are present in oral and non-injectable, and in injectable forms. So that's what they're trying to say. Excuse me. Next one is over here, diabetes mellitus. Okay. Increased insulin sensitivity, we have metformin and calzones. Okay. The mechanism of actions, they are very high yield. Adverse effects, very high yield, especially for metformin. You have to remember this one. Use in caution with renal insufficiency. They can also cause vitamin B12 deficiency. Pioglitazones, very important. They will ask you which drug is responsible for causing heart failure, fractures, and weight gain. Okay, so that's that. Pioglitazones, metformin, both of these are important. Over here, meglitanides are not that high yield. Sulfonylureas, okay. Sulfonylureas are high yield. The mechanism of action is high yield. We talked about this already. They can cause a disulfiram-like reaction. What is a disulfiram-like reaction? Patients who are taking sulfonylureas, they cannot drink alcohol, because whenever they drink alcohol, they will have excessive hangover, nausea, vomiting, excessive headache, blurry vision, and all of these things, which are your sign symptoms of disulfiram-like reaction. Since sulfonylureas contain sulfur for obvious reasons, we have to make sure that patients do not drink alcohol with this. Okay, this is also a question for your step 1 exam. Over here, out of this one, GLP1 or DPP4, GLP1 is more high yield. You'll get more questions from over here. This one is plus minus, so put more attention to these ones. Mechanism of action is not very important. What is important are the side effects. DPP4 Once again, mechanism of action is not important. What's important is the fact that they also increase satiety. They can also cause respiratory and urinary infections, but the amount of questions you choose receive about this is very low. But still, there's a potential that you guys can be asked about this, that they can cause respiratory infections and urinary infections. If you ask me why, then I do not know. If you ask Google, even Google will not know why. Okay, so no one knows why they cause this. Next one is sodium glucose cotransporters. These are high yield. The mechanism of action is not high yield as much because the name says itself, sodium glucose cotransporting inhibitor, so we know what's happening. So you will not be tested on the mechanism, what you will be tested are on the side effects. And the fact that you have to use it with caution in patients who are suffering from renal failure. Okay, this one, acarbose high yield. You'll be asked about this, that they work in the intestines, right? And over here, the mechanism of action is more important. The side effects are not that important. Okay. There's another group of drugs which I think I forgot to mention, and also this is not very high yield, but these are amylin drugs. They act like Glp1 agonists, and they cause hypoglycemia. Okay. They are not high yield, plus minus. Okay, so with that being said, we're done with the anti-diabetic drugs. Is everyone clear? Yes or no? Is everyone clear about this? Okay. So I apologize for taking this long to talk about the anti-diabetic drugs. I'm not sure if you guys have gotten bored or not, or if you guys have been a little bit out of it. But the reason is because I took some time to talk about the anti-diabetic drugs and the different ways that we can do this is because the amount of questions, guys, which you will receive from over here is immense. This is absolutely, absolutely important, very, very high yield. So how do you make sure that you remember all of this information over here? The fact that I used my previous information, the ones which, I mean, when I studied for step 1, I used to study the anti-diabetic drugs each and every day, more or less. At least once I would look at the drugs because the thing is, there's a possibility you forget this. So since I did that, right now I'm able to take the lecture because whenever I think about the drugs, I instantly remember what the mechanism of action is, what the adverse effect is. So I suppose you guys should also be on the same level when you talk about the anti-diabetics. That is, you should have a very clear-cut idea about the names, mechanism of action, and the adverse effects of the drugs. The way that you should do this is very simple. Take a blank page, okay? Take a blank page. In the blank page, have 3 columns: drugs, mechanism of action, adverse effect, okay? For example, your first drug is, write down the name, metformin, mechanism of action, decreased hepatic gluconeogenesis, adverse effect, lactic acidosis. And if you have any special notes, write down. Do not give it in patients who have do not give this in patients who have increased serum creatinine. Okay, for example, then the next one is your glitazones, right? Thioglyt, you write zones, only zones, so that you remember with zones you have thiaglitazone and then thioglytazones. Then your mechanism of action, write down that they increase PPAR and adiponectin. As a result, you do not have to write the rest. You can remember easily that they will decrease lipolysis, decrease gluconeogenesis. Adverse effect, they're very important because they cause weight gain and heart failure. So did you guys understand how you should make your small page notes so that you can post it on the wall? Yes or no? So that you can post it on your wall? Yes or no? Yes? Okay. So let's say you have your study room, you have your desk right in front of your desk. If you have a wall for the next 6 months that you prepare for the exam, try to make sure that you keep this sort of information on your wall so that whenever you sit down to study and you look at the wall, you can instantly revise the anti-diabetic drugs in a matter of minutes. And you keep on seeing it every day for the next 6 months. At one point, whenever you think about the drugs, you can name all the disease, all the actions, adverse effects, names, and everything else, and easily answer the question. And whenever you get anti-diabetic questions in step 1, you can easily answer all of the questions related to this topic. Okay, so that's that. Are we clear? Yes or no? Does anyone have any questions from anti-diabetic drugs? Okay, so can we do a quick revision and recapitulation of anti-diabetic drugs, since we also have our exam tomorrow? Yes. The way that we will do this is, let me see how the students are participating in the class. So I'll ask one by one, okay? And when I ask a particular student, I would expect the other students to not tell me the answer, because this will allow me to understand if students are understanding properly, if they're present in the class or not, and what's going on. Okay, is everyone ready? Yes or no? Can everyone hear my voice? Is everyone ready? Okay. So let's start with the first student over here. What we have is Dr. Carissa McLean. Thank you so much for joining the lecture. Hope you're doing well. The first question to you is, which of the following insulins will have no peaking? Insulin Lispro, Aspart, Glutathione, or Glargine? Which one will have no peak? Yes, I can hear you. Thank you so much. Which one of the following, Lispro, Aspart, Glutathione, or Glargine, will have no peaking? Very good. Thank you so much. So the answer is Glutathione. Very good. Next one is for Dr. Dahlia. If you have a patient who comes to you who wants to be prescribed metformin, but the patient has a history of having hemodialysis, will you give him or her the metformin? Yes or no?
No.
Why?
Can you repeat your question?
Why will you not give metformin to a patient who is undergoing hemodialysis?
Because of the side effect of the treatment, metformin, it can cause lactic acidosis.
Okay, so you are correct. Metformin does cause lactic acidosis, but this is not the reason why they can cause renal insufficiency. The reason why they will cause renal insufficiency is because metformin is broken down and it's eliminated from the body by the renal system. So we do not want to pressurize the renal system anymore. Okay.
Okay.
Very good. Thank you. Thank you so much for your answer. Can we have the next question for Dr. Nazaret? That is, what is the name of the drug that will activate PPAR gamma?
Zones, the end with zones, rosiglitazone.
Very good. Pioglitazone and rosiglitazone. Very good. Next one is okay, Dr. Inas Yasin. I'm not sure if you're here. What is the adverse effect of glutazones? Okay, this question goes to the next. Yes, we have Dr. Inas Yasin.
Yes, hi. Yeah, galactazone increase leading to weight gain, and it can increase the risk of bone fracture.
Okay, very good. Will you give this drug to someone who is suffering from heart diseases?
No, we didn't give it to patient with heart failure or any heart disease.
Thank you so much. Next one is for Dr. Hagar. If you have a patient who comes to you with hypoglycemia, you find out that the patient has abused an anti-diabetic drug, and you see that the insulin is high, C-peptide is high. Which anti-diabetic medication do you think the patient has abused? Okay, let's move forward to the next physician, Dr. Jorge. Which anti-diabetic medication do you think the patient abused for increased insulin and increased C-peptide in the blood? You have a patient who comes to you with hypoglycemia. You find out it's a factitious problem. you find out that insulin and C-peptide is high, and there's a possibility the patient abused an anti-diabetic drug. Which anti-diabetic drug do you think he abused, he or she abused? Okay. Okay, let's move forward. Sulfonylurea, very good. Thank you so much. Okay, let's ask the next question to Dr. Manahil, if you're here. Which drug is responsible for causing nausea, vomiting, pancreatitis?
Tired, the end was tired. Glp1.
Very, very good. Thank you so much.
Thank you.
Let's move on to the next physician, if that is Dr. Mridula. Which drug do you think can cause, can you tell me how exenatide and liraglutide, how do they work? The mechanism of action?
They act like glucagon, so they decrease the glucagon release,
Okay,
which in turn increases decreases the glucose in the body.
okay. And do
It
they increase
also-
gastric emptying or decrease
No, it
gastric?
also decreases gastric emptying.
Very good. Thank you so much. Okay, thank you so much for your answer. Let's move on to the next physician. Who else is here? Thank you. Let's ask the question to our next physician, Dr. Nafisa. What is the name of the drug you'll give for prevention of glucose absorption and the proximal convoluted tubule?
Question again, please.
Which drugs will you give for prevention of reabsorption of glucose in the proximal convoluted tubule?
I cannot hear you good.
Which drug will you give to prevent the reabsorption of glucose in the proximal convoluted tubule? Can you hear me now? Can everyone else hear my voice?
Again,
Yes.
one more time again, please.
Yes, of course. Which drug will prevent the reabsorption of glucose at the proximal convoluted tubule? Okay. Okay, no problem. Let me move on to the next physician. Okay, let's move on to the next physician. So we asked the question to Dr. Nafi. So let's move on to Dr. Ibrahim. What is the name of the drug that prevents reabsorption of glucose in the proximal convoluted tubule? Dr. Ibrahim.
Claudine drug.
Very good. Thank you so much. Claudine group of drugs. Okay. Next question for Dr. S. How do they block the reabsorption? Which channel do they prevent or block?
They block sodium channel.
Very good. They block the sodium glucose cotransporters. Okay.
Yes.
Next one is Dr. Rafiq. Let's ask the next question to Dr. Rafiq. What are the side effects of clozins?
Sir, can you repeat the question? Side effects of what?
Clozins, that is GLP-2 inhibitor. Sanagliflozin, dapagliflozin.
Oh, yes, sir. So it causes weight loss and UTIs and candidiasis in female patients.
Thank you so much. Next question for Dr. Sanjeeva. That is, how or what is the mechanism of action of the drug acarbose? What is the mechanism of the drug acarbose? Acarbose. Okay. Mic not working, no problem. You can use the chat box. Good. Acarbose, how do they work? Very good. Thank you so much. They decrease the glucose absorption from where? Intestines, kidneys. Where do they? No problem. Looking at you, sir. It's okay. They have sound problems. Okay. Intestines. Thank you so much. Let's move on to the next physician, Dr. V.K. If you are giving a drug that is decreasing glucose absorption from the intestines, What are the side effects you expect in your patients, Dr. V?
GI upset, it's diarrhea, bloating.
Oh, very good. Thank you so much. Okay, good. I think the last question goes for Dr. Tasneem over here. Acarbose, Neglitol, canagliflozin, dapagliflozin, can you prescribe them for patients with renal insufficiencies?
No.
Okay. Can you prescribe metformin for renal insufficiency?
No.
Okay, one more question. That is, if you have to prescribe a drug to a patient who has diabetes and weight gain, and the patient wants to promote weight loss, which drug will you choose?
Exenatide liraglutide.
Perfect. Thank you so much. Okay. Now this question, the one which I asked, was the last question. Promotion of weight loss in patients with diabetes. This is a very high yield question. GLP1 agonist. Okay. If you have answer options like this, okay. For example, they ask you a question that a patient comes with diabetes, and the patient wants to promote weight loss, right? And your answer options are something like this: metformin, exenatide, liraglutide, and that. And then you have another one that is your gliptins, right? Then you have acarbose. Now, obviously, you know that gliptins and acarbose, they stand no chance in terms of decreasing weight gain when you compare them to metformin, exenatide, and liraglutide. So they are obviously the wrong answer. Out of these two, if you ever have to choose, always choose metformin first. If the answer option contains metformin, if metformin is not there, then your most obvious choice of answer is exenatide or liraglutide. Have I made myself clear? Yes or no? Okay, good. Thank you so much. So with that being said, we're done with the anti-diabetic medications. We only have 2 more pages, which we will finish before we will start doing the questions. So can we take a short break for 15 minutes before we begin these last 2 pages? Yes or no? So thank you so much for your utmost attention in the class. I really appreciate it. Let's take a break for 15 minutes to sort of let our neurotransmitters get repleted with, or our synapses get repleted with neurotransmitters, right? And let's come back at 11:48. Let's come back at 12:05 p.m. Thank you so much. Okay, is everyone back from their break? Can you guys hear my voice? Yes or no? Okay, let's begin. Okay, let's begin with the lecture. Okay, so we have Dr. Ithar who's back, Dr. Nazar who's back. Is everyone else back? Okay, let's begin. Okay, so we are going to talk about anti-thyroid medications and thyroid medications, anti-ADH medications and ADH medications. Then we'll talk about a little bit of bisphosphonates, and then we'll end our lecture from first aid. Now, I'm not going to use my blank page anymore for these ones because these drugs are very straightforward. They will tell you exactly what they will do, and you will not have a difficult time remembering what these drugs are used for. Number one is anti-thyroid medications. First and foremost, if you have a patient with hyperthyroid, the first group of drugs you want to give are, always remember that these drugs are beta blocker, especially propranolol, right? So if you're ever given a question where you have to choose whether you want to prescribe propranolol or anti-thyroid medications, always choose beta blocker and propranolol before you give anti-thyroid medications. But before you give beta blockers to the patient of hyperthyroid, before you give them anti-thyroid medications, you need to make sure that the patient does not have bradycardia. The patient does not have asthma or any sort of heart failure, which is a contraindication. If the patient does not have bradycardia, if the patient does not have asthma, no history of heart failure, and the patient has hyperthyroidism, then it's safe to prescribe beta blockers first. The second group of drugs you'll obviously prescribe if beta blockers is not working are your anti-thyroid medications, that is propylthiouracil and methimazole. These are the anti-thyroid medications. The third group of drugs that you will prescribe after this is radioactive iodine or potassium iodide. So that's that. Now, let's talk about the anti-thyroid drugs. We have two drugs, propylthiouracil and methimazole. The mechanism of action is very high yield and very simple. The thing that they will do is that we know in the thyroid follicular cells, if this is the thyroid follicular cells, we have the sodium iodide co-transporter. The iodine will go, and over here, the iodine will get oxidized by thyroid peroxidase. Thyroid peroxidase will not only conduct oxidation of iodine, it will also conduct organification, right? They will cause the binding of iodine with thyroglobulin. Where do we get thyroglobulin from? Thyroglobulin is produced in the thyroid follicular cell with the help of the amino acid tyrosine. So that's that. And the way that propylthiouracil works is that they prevent or they block thyroid peroxidase, prevent oxidation, organification, and prevent the formation of MIT and DIT. That's that. So as you can see, they have said the exact same thing, which I just mentioned, inhibition of the oxidation of iodide as well as organification. So these two processes are blocked. As a result, we do not have thyroid hormone production. And over here, propylthiouracil also, in addition to blocking thyroid peroxidase, will also block 5' deiodinase. We all know what 5' deiodinase is responsible for. 5' deiodinase will cause the peripheral conversion of T4 to T3, and T3 is the most active form. So thionamides, especially propylthiouracil, will block two drugs. Okay, so that's that. The next high yield question you'll receive regarding anti-thyroid medication are the medications which you will give in pregnancy. Always remember, in pregnancy, in the first trimester, you will give propylthiouracil. You will not give methimazole because in the first trimester, we have the development of the major organs and then the body. When we study embryology, we'll talk about the development of the major organs, which happens from week 3 to week 8. Right? And it's in this period when our mother conceives a child, that is from the 3rd week to 8th week, we need to make sure that the mother is not taking any medication, drugs, or anything, or any supplement which can hamper the development of the major organs of the baby. So that's that. Since methimazole has
the possibility of being a possible teratogen, especially because it can cause aplasia cutis. What is aplasia cutis? Aplasia cutis is basically the aplasia means absence, cutis is the Latin word for skin. So aplasia cutis means absence of skin. Let me show you a picture of what methimazole can do in a child. Aplasia cutis. Okay. This is aplasia cutis, right? Skin abnormalities, right? So we obviously, as you can see over here, aplasia meaning absence of skin, and this exposes the cranium of the child. So we do not want the patients to have these sorts of conditions. So we will prevent aplasia cutis. The reason why I'm showing you this picture is because these pictures will be shown in the step 1 exam. Okay, so this is aplasia cutis. Okay, now, so in the first trimester, you will give propyl thiouracil. In the second trimester, you will give methimazole. In the second and third trimester, you can give methimazole. Keep in mind, in the second and third trimester of pregnancy, if the mother has hyperthyroid, you have to switch propyl thiouracil to methimazole. The reason being is because in the second and third trimester, propyl thiouracil can cause severe damage to the mother's liver. We know that during pregnancy, the livers of the mother are very prone to develop hepatitis, especially by hepatitis B, which can result in fulminant hepatitis and result in the death of both the mother and the fetus. So to prevent any further damage to the liver and to maintain the integrity of the metabolic pathways, we need to make sure that propyl thiouracil is not given in the second and third trimester, and we switch it to methimazole, because in the second and third trimester, the major organs of the baby's bodies of the baby has already developed, so it's safe to prescribe this drug. Clinical use is obviously, we give them in hyperthyroid, right? They have said the exact same thing, which I said, that in first trimester of pregnancy due to methimazole, and methimazole is used in the second and third trimester because of hepatotoxicity. This is exceptionally high yield. You'll get a bunch of questions from this portion over here. Keep in mind, we do not give methimazole or anti-thyroid drugs to treat Graves' ophthalmopathy. In Graves' ophthalmopathy, there is a thyroid stimulating immunoglobulin that binds to the TSH receptors. Where do they bind? They bind to the TSH receptors at the, for example, this is the eye. We have glycosaminoglycans, which contains TSH receptors, and TSIG will come and bind to the glycosaminoglycan, leading to expansion of the glycosaminoglycans, and this can cause ophthalmopathy. So we cannot give propyl thiouracil and methimazole to treat ophthalmopathy because propyl thiouracil and methimazole works exclusively only in the thyroid gland. Okay. Whereas for the treatment of Graves' ophthalmopathy, we are supposed to give the patient corticosteroid. This is another sort of a thing. Now, corticosteroid, what they will do is that they will prevent the autoimmune attack by the thyroid stimulating immunoglobulin, prevent its binding to the TSH receptors, and it will prevent the ophthalmopathy, as simple as that. So please try to remember this, that Graves' ophthalmopathy treatment is not with anti-thyroid medications. You will be tested on this concept time and time again. What do we give to treat Graves' ophthalmopathy? The answer is corticosteroids. Okay. So adverse effect wise, they can cause skin rash, agranulocytosis, that is rare. What they can also cause is they can cause aplastic anemia, which I need you to focus on over here. Patients can get decreased hemoglobin, white blood cell count, and platelets if they are being treated with propyl thiouracil and methimazole for a long period of time. Hepatotoxicity will also happen over here. Okay. Propyl thiouracil has been associated with anti-neutrophilic cytoplasmic antibody positive vasculitis, but it's not high yield. You will not receive any question regarding this concept. So that's all you need to know regarding propyl thiouracil and methimazole. Let's move on to the next one, that is levothyroxine and leotyronine. Levothyroxine is a T4 analog, leotyronine is a T3 analog. Clinical use, obviously, these are thyroid hormones, so they need to be prescribed in patients who are suffering from hypothyroidism, right? Some patients who do not have hypothyroid, if they can get access to levothyroxine, they may abuse levothyroxine for weight loss. This is also high yield because exogenous administration of T3, T4 can also decrease your TSH, and patients can have signs and symptoms of a hypothyroid attack. So that's it. So they may be abused for weight loss. We all know how thyroid hormone can contribute to weight loss. Thyroid hormones, these are your steroid hormones. They will increase the production of sodium potassium ATPase, increase the basal metabolic rate, and whenever your BMR is high, you will lose weight, as simple as that. We all know how we can measure and we can distinguish hyperthyroidism from endogenous hyperthyroid by using a combination of TSH receptor antibodies, radioactive iodine uptake, and measurement of thyroid blood flow. Basically, what they're trying to say is, how can you differentiate hyperthyroid caused by exogenous administration or increased production? The thing is, if we have a patient who is taking thyroid from outside, and when we do a radioactive iodine uptake, we will see that the radioactive iodine uptake in the thyroid gland itself is low and the thyroid production is high. This will give us an idea that the patient is abusing thyroid. Next one is thyroid blood flow on ultrasound. If a patient is abusing thyroid from outside, then thyroid blood flow to some extent will also be low because the work conducted by the gland itself will also decrease, so the blood flow will also decrease. And that's that. What are the adverse effects of levothyroxine and leotarine? They can cause tachycardia, heat intolerance, tremor, arrhythmia. These are basically the normal things that happens in a patient of hyperthyroid. So that's it. Are we clear, yes or no, about the thyroid medications, everyone? Yes, okay. Let's move on to the next drug, hypothalamic drug and pituitary drugs. Okay, over here, let me just tell you right away, demeclocycline, extremely important, desmopressin, extremely important, somatostatin, extremely important. Okay, these are the three drugs which you will get tested on in your step 1 exam. So let's talk about them first. Demeclocycline is an ADH antagonist. Please keep this in mind. And desmopressin is an ADH agonist. As simple as that. So if someone has SIADH due to small cell carcinoma, pneumonia, carbamazepine use, or anything else, if they ask you which drug will you prescribe to this patient to prevent this excessive action of ADH, the drug is demeclocycline. And personally, I can tell you that I remember this being a question from my actual step 1 exam. Okay, so this was there in my exam, demeclocycline. Desmopressin, however, is an ADH agonist. They will work as an ADH when patients who are suffering from diabetes insipidus. Another thing is desmopressin has also shown to increase the release of von Willebrand factors, right? In patients of von Willebrand disease, we can also give desmopressin to some extent, but we'll not talk about von Willebrand disease, hemophilia, and sleep enuresis right now. Since we are on the topic of endocrinology, we'll focus on two things: central diabetes insipidus and sleep enuresis. That is urination or micturition during sleeping, especially in young children who have excessive nocturia. After the first treatment for excessive nocturia, number 1 is your bladder. Basically, we say bladder control, meaning that we try to, what's the word I'm looking for? The word that I'm looking for is practice, right? Healthy bedtime practices. That is, what are some healthy bedtime practices for patients who have difficulty holding on to their urine? Basically, we try to make sure that they do not drink a lot of water before they go to bed. We need to make sure that they go to bed at a certain period of time, right? Then we try to make sure that if they feel like they need to go to the bathroom when they are sleeping, we need to practice the patients to wake up and go to the bathroom and then release the urine. If that doesn't work, if bedtime practices and everything, if they don't work, then the second line group of drugs which we can give to prevent micturition during sleeping is desmopressin. Okay, as simple as that. So that's what it is. Next one is somatostatin, and we all know how important somatostatin is. Somatostatin will be basically used for the treatment of majorities of pancreatic neuroendocrine tumors, including carcinoid syndrome, carcinoma, glucogonoma, and esophageal varices. How do they work for esophageal varices? We'll talk about the details with the GIT. But just to let you know, in esophageal varices, somatostatin or octreotide, they will cause splanchnic vasodilatation. Vasodilatation. Okay. And this promotes the prevention of the formation of the varices. So that's that. Okay. Another group of drugs that is high yield, but you already know this drug. This is oxytocin, and we all know when we use oxytocin. Oxytocin is basically prescribed for patient for initiation of uterine contraction, so that in patients who have difficulty or prolongation of labor, we can give oxytocin in drips, and it can also control uterine hemorrhage in a patient who is suffering from severe PPH. PPH stands for postpartum hemorrhage. So that's that. Okay. Next one is we have another sort of antagonists. After demiclocycline, we can give them conivaptan and tolvaptan. You can try to remember this if you want. If you do not want to remember this, no problem. Okay. And we obviously know where we will give growth hormones. Growth hormones are basically prescribed for growth hormone deficiencies and Turner syndrome. Turner syndrome is 45XO, meaning that females, they usually have 46XX. If due to anything, for example, genetic mosaicism, or for any other reason, if one X chromosome is deleted, then females have 45XO. 45XO results in a sort of disease where the females are short-statured, webbing of the neck, there is a broad chest, streak ovaries, and all of these conditions. In those conditions, to promote normal growth of the females, we can prescribe them growth hormones. Okay, are we clear? Yes or no? Everyone? Are we clear? Yes. Okay. Good. Next one is fludrocortisone. What is fludrocortisone? Fludrocortisone is a type of a synthetic analog for aldosterone, meaning that in patients who have deficiencies of aldosterone production, that is especially in, for example, adrenal insufficiency, primary adrenal insufficiency, because we know in secondary and tertiary adrenal insufficiency, we do not get aldosterone absence, because in secondary and tertiary adrenal insufficiency, the problem is with ACTH. And we know ACTH directly does not affect aldosterone level. So only in primary adrenal insufficiency do we give mineralocorticoid replacement. Okay, as simple as that. What will they do? Their action is very similar to aldosterone. So they will cause hypertension or increase of blood pressure. They will cause increased loss of potassium in the urine and increased absorption of sodium. So that's that. So we have to give them in controlled amounts, or else if patients already have heart failure, they can get exacerbation of heart failure. So that's that. So we know that in heart failure, patients have a difficulty pushing blood out of the heart. So in those cases, we do not want to increase the blood volume. So you have to be very careful. Okay. So that's all you need to know about fludrocortisone. Please do not forget this, fludrocortisone. You will get 5 to 6 questions regarding fludrocortisone. Very basic, straightforward questions in your USMLE step 1. This will be easy questions, but the stars are to help you understand that this is important. Okay, next one is cinacalcet. What is cinacalcet? Cinacalcet are basically patients who are suffering from decreased calcium sensation. For example, they sensitize the calcium sensing receptor and they decrease the parathyroid hormone. For example, in patients who are suffering from secondary hyperparathyroidism, for example, you have high calcium levels, but they're not being able to decrease the secretion of parathyroid. Right. So what we do is that we use cinacalcet to sensitize the calcium receptors in the parathyroid gland. So a small amount of calcium can decrease the secretion of parathyroid. So that's that. So that's why cinacalcet is used. Adverse effect wise, they can decrease the parathyroid hormone to such a level that at one point they will not be able to increase the calcium. So patients can suffer from hypocalcemia. If you ask me how high yield or how important cinacalcet is for the exam, then my answer to you would be that the questions on cinacalcet is very low. I highly doubt you will even receive 1 question or 2 questions. So it's safe to say that it's not very important. What, however, is important is, sevelamer is not very important either. Sevelamer is basically a phosphate binder. They bind to the phosphate, and basically in patients who have CKD, they have a difficulty in getting rid of the phosphates. because a parathyroid hormone cannot work properly to get rid of the phosphate in chronic kidney disease. In those conditions, we give phosphate binders, which binds to the phosphate and it prevents the renal release of phosphate and allows the phosphate to get released through the feces. So that's it. So if they are allowed to release through the feces, then what happens is that phosphate gets trapped in the intestinal lumen with the help of this drug, that is sevelamer, and they act as an osmotically active substance, which sort of absorbs more water. So that's that. So water absorption also increased, and as a result, patients can get GI upset. Once again, how high yield is this? The answer is it's not very high yield. You will not be seeing any questions from over here. Okay. Next one is cation exchange resins. This is high yield. These are basically potassium binders. Exactly how sevelamer binds to the phosphate and releases the phosphate through the feces. We have pariromar, sodium polystyrene sulfonate, zirconium, and your cyclosilicate. Now the thing is, do you have to remember the names of these drugs? The answer is no. Or you only have to remember the name of one drug, that is this one, pariromar. Sodium polystyrene sulfonate, zirconium, and cyclosilicate, they are not tested in the step 1 exam. If you want to remember one more drug besides pariromar that can be important, it's this one, zirconium. Zirconium has 1 or 2 questions in step 2 CK, not in step 1, but still. Okay, so that's it. So basically the mechanism of action, what is the mechanism of action? They will bind to the potassium in the colon and they're excreted in the feces. When do we prescribe this? Obviously in the case of hyperkalemia, right? What are the treatments of hyperkalemia? First of all, in hyperkalemia, we have to give the patient insulin plus glucose. The insulin would shift the potassium into the cell, right? Then the next thing that we have to make sure is if the potassium level is very high, we give a drug that protects the heart. That is calcium gluconate to prevent arrhythmias. Next one is we can give furosemide to decrease calcium reabsorption from the ascending limb of the loop of Henle. And the second is we can give potassium binding resins. That is pariromar. Okay. So that's that. And with that being said, okay, we are done. Okay, so congratulations on finishing endocrinology. Do you guys have questions for me? Any questions? Okay. Any questions, yes or no? If yes, I'll answer them. If no, I'll move forward. No, okay. If no, then let's do a couple of review questions, then I'll move on to AMBOSS. First and foremost, which drug will you prescribe for hyperthyroid treatment in first trimester? Very good. Why will you not give methimazole in first trimester? Okay. Next one is which drug will you give for the treatment of SI-ADH? Treatment of SI-ADH. Demeclocycline, very good. Which drug will you give for the treatment of diabetes insipidus, central diabetes insipidus? Okay. Which drug will you give for increasing uterine contractions in pregnancy and prevention of PPH? Which drug will you give for treatment of pancreatic neuroendocrine tumors and esophageal varices? Okay. Which drug will you give in a patient of diabetes, the first group of drug, anti-diabetic medication in type 2 diabetes? Will you give metformin in a patient suffering from renal insufficiency? Okay, which drug will you give? Which drug will you not give to a patient suffering from weight gain, heart failure, history of factors? Very good. Which drug will you give to promote weight loss in patient of diabetes? Okay, which drug will you give to a patient for which drug will you give to a patient for prevention of intestinal absorption of glucose? Okay, good. Thank you. So are we confident about endocrine drugs? Yes or no? Okay. So let's begin with the questions. Is everyone ready? Okay. Okay, let's begin with the first one. How do you read a step one question? Read the last line first, read the answers, then you move on to the question over here. Okay. If she does not receive adequate treatment for her condition, which of the following complications is the infant at risk of developing? Okay. Now, wait for a second. Do you want me to read the questions with you, or do you want to solve it by yourself first? Because a lot of students might face difficulty focusing on the question when I'm talking at the same time. Can I get some feedbacks? Self? Okay. Self. Okay. So if you guys want to solve it by yourself, then you have to solve it under a certain timeline. Okay. So you have the time over here, right? At exactly 1 minute and 30 seconds, I'll move on to the next question. Okay. Is everyone ready? Okay, let's begin. Okay. Can everyone hear my voice? Yes or no? Done. Very good. Okay. Thank you so much. Let's begin. How were the questions? Easy or not easy? Were the questions easy or not? Okay. Let me ask another question. Were the questions familiar or not? Were the questions familiar? Moderately easy. Okay, so let's begin. Keep in mind, AMBOSS is very difficult, so it's bound to be a little bit on the harder side. Your questions are much easier than AMBOSS. When you solve them, you will understand. Okay, are we ready? Yes or no? Okay, now let's begin with the first one. If she did not receive adequate treatment for her condition, which of the following complications is this infant at risk of developing? Let me see your answers on the chat box. 26-year-old woman, 23 weeks of gestation, no serious illness. She shows glucose this. If she does not receive treatment, what will she have? Okay, very good. The answer is islet cell hyperplasia, right? Obviously, because glucose will cross the placenta, and the high amount of glucose in the young child will promote the release of insulin, and so pancreatic islet cell will undergo hyperplasia. Next question. I think we did this once before. Scatter plot. Which of the following is a possible explanation for the group marked with the letter E? So over here you have low parathyroid and high calcium. This one is very good. Parathyroid related peptide lymphomas. Okay, next one. 57-year-old woman comes to the, sorry, my apologies, man comes to the ER for evaluation of worsening fatigue. Okay, so hypercalcemia-like complications, metastatic bladder. He has smoked one pack of cigarettes. Okay, shows a shortened QT interval. Which of the following sets of the serum findings is most likely in this patient? Which one did you guys choose? Fast answers, please. This one is pretty easy, right? Very good. Let's move forward. This was a very difficult question, as a matter of fact, with 4 hammers. So congratulations to everyone who has given the right answer to this. This is a case of the release of ectopic secretion of parathyroid hormone-related peptide. Okay. Let's move on to the next one. 45-year-old woman comes for health maintenance. Okay. She has gained weight, hyperpigmented plaques, hemoglobin A1C. Which of the following factors is most likely involved? Which one did you guys choose? Fast answers, please. Which one did you guys choose? Okay, so this patient has acanthosis nigricans. Okay, the answer for this one is obviously B, right? Why will it be B? B because if there's increased levels of adiponectin, what will adiponectin do? Adiponectin, what will adiponectin do? If there's increased levels of adiponectin, then what would happen to lipolysis? Decreased lipolysis. So as a result, there will be decreased gluconeogenesis. So there will not be diabetes. So if there's no diabetes, how can you expect patients to have acanthosis nigricans, right? So the answer is increased levels of fatty acid. Okay, very good. Okay, next one. 37-year-old woman, gravida 3 para 2, 28 weeks gestation, oral OGTT shows elevated glucose level. She is compliant with the recommended diet. Over the past week, home blood glucose shows elevated fasting and postprandial glucose levels. Which of the following describes the mechanism of the pharmacotherapy? Which one of this is the correct answer? Very good. Very, very good. Insulin. Insulin is the group of choice for gestational diabetes. For gestational diabetes, we will always give insulin. Do you remember this from the text we said in type 1 diabetes and gestational diabetes, we will give insulin, and insulin will bind to the tyrosine kinase receptors. Next one. 55-year-old woman with type 2 comes to the physician for evaluation of worsening tingling of her feet. Okay, this is which of the following additional findings will you find? Okay, this is a complication of diabetes mellitus. Okay, very good. Because if someone has peripheral neuropathy, then they should have incomplete bladder emptying. What happens in a patient of prolonged diabetes? If this is the bladder, right? If the bladder is full, it will push on the stretch receptors and they will go to the central nervous system and initiate the micturition reflex. But over here in diabetes mellitus, the stretch receptors will not invoke an action potential because there is peripheral neuropathy. So there's loss of transmission of impulse. So patients will not be able to invoke the micturition reflex. Even if they do invoke a micturition reflex, the reflex will not work properly because once again, the motor fibers coming over here, trying to contract the detrusor muscles will not work once again because the patient already has peripheral neuropathy. Did everyone understand this answer? Yes or no? It's a very important one. This is very, very important. 47-year-old woman comes to the physician because of a 2-month history of a lump. Okay, on her neck, red PTC. What will you find on microscopic examination? This is the, my apologies. I don't know why I chose this. Okay, very good. This is the one. Okay. So that's that. Everything over here. Okay. Now, let's look at this. Genetic analysis shows red pre-TC chromosomal invasion, firm non-tender nodules, thyroid malignancies. Histopathology shows lymphatic invasion. Microscopy will show your microscopy will show your calcified spherules and large ovules within empty appearing nuclei. Now over here, there are 2 types of things that you will see. Either it could be medullary, either it could be papillary. Now, how do you know whether if it's a medullary thyroid carcinoma or whether it's a papillary thyroid carcinoma? The answer for this one is in medullary thyroid carcinoma, there will not be lymphatic invasion. When do we get lymphatic invasion? Lymphatic invasion happens for carcinomas, okay? Lymphatic invasion happens for carcinomas which are of squamous type, squamous carcinomas. Medullary thyroid carcinoma is not a squamous type of carcinoma. Medullary thyroid carcinoma is more or less like an adenocarcinoma-like structure. Squamous carcinoma is very similar to papillary thyroid carcinoma because in papillary carcinoma, the cells, they turn into papillary cells like this. So these cells, they can readily cross the placenta, okay? My apologies. These cells, they can readily cross the lymphatic system. Okay, my apologies, not the placenta. Okay. Do you guys understand this question or not? Okay. No crossing the placenta, that was a mistake. Do you guys understand this? Lymphatic invasion, not obviously not placental invasion. Okay. Okay, good. Let's move on. My apologies. Okay. When you have been taking classes for so long, at one point you just start saying rubbish. So I apologize if something like this is happening. Okay, let's move on. Now, a 48-year-old woman comes to the physician because of a 3-month history of fatigue, polyuria, blurry vision. His BMI is 33, blood pressure is this. Urine analysis shows 1 glucose protein ketone. Which of the following is the most appropriate management? Okay. Listen up, bro. Okay, let's see if that's the correct answer. Very good. Okay. So that's that. Not only will lisinopril prevent cardiovascular diseases, it will also prevent renal progression. So this is the best choice of answer. Okay. Are we clear, everyone? Yes or no? C, aspirin therapy. We will not give aspirin initially. We only give aspirin for patients who have 10-year cardiovascular risk of more than 10%. 75-year-old woman brought to the physician by her daughter. Okay, I think we did this, right? Okay, we'll move forward. You guys remember this one? We did this. So if you chose this one, then it's the correct answer. The reason why this is being repeated so many times is because it's a very important question, that's why. 75-year-old woman, seizure disorder, my apologies, 75-year-old man, not woman, once again, with a seizure disorder by a friend because of progressive confusion over the past 2 weeks. Is unable to provide any history. Okay, very easy. Very good. This is carbamazepine. Okay, due to carbamazepine because of convulsion. So the patient is suffering from SIADH. Next one. high lipid diet 2 months ago. Okay, a high lipid diet has a significant higher average group. Which of the following intracellular changes is most likely involved over here? Which one of this is the correct answer? Okay, very good. The correct answer for this one is B. Okay, it's not E because in E you have decreased production of protein kinase A, but although E is also a very close choice. The reason why this one is the correct answer is because when you have someone who is taking a high lipid diet, they're more prone to develop insulin resistance. So which of one of the following intracellular changes is most likely involved in the pathogenesis? So basically, when you have increased insulin resistance, you have increased activity of the serine kinases. These kinases, they will inactivate the insulin receptor. Okay, so that's that. Please write this down in your first aid that insulin resistance is linked to increased activity of serine kinase. This is a possible question in your next exam. Okay, yes, TNF alpha can also do this. Okay, please write this down. TNF alpha, glucocorticoids, and catecholamines. These three things can also do the same thing. Please write this down in your book. After you're done writing this down in your book, please write it down in the chat box so that I can move forward. Please write down if you're done writing this in your book. Okay. Did everyone write this in their book? Okay, next one. Clinical trial is conducted to investigate the efficiency of new glucagon receptor antagonists. After 12 weeks of treatment, all participants study achieved statistically significant reductions in fasting and postprandial glucose. The individual reports symptoms of hyperglycemia while exercising. The activity of which of the following enzyme is most likely to be decreased in response to this treatment? Which one of this is the correct answer? Protein kinase A. Very good. Okay. The answer for this one is protein kinase A, because over here, glucagon will switch glycolysis to gluconeogenesis, and we know that protein kinase A is decreased in response to glucagon receptors. So that's that. We will discuss this in details in biochemistry, but for now, try to understand that protein kinase A is responsible for gluconeogenesis. So that's why over here, I mean, my apologies. The protein kinase A is not really dependent on glucagon-like activity, so that's why this is the correct answer. Okay, I'll talk about this in details in biochemistry. Can we move forward to the next question? Yes. Okay. 41-year-old woman comes to the physician because of 3-month history of anxiety, difficulty following, heat intolerance. Okay, sounds like a hyperthyroid. Which of the following would suggest a different etiology other than the one described by her nephew? Okay. Okay, very good. Because in Graves' disease, you're not supposed to have this non-pitting edema. So Graves' disease is the correct answer. Okay, so that's that. Okay, let's move on to the next question. 15-year-old girl is brought to the physician by her mother because she's concerned that her daughter has not started puberty. Okay, chromosomal analysis shows 46XY because this is a male, not a female. So a defect in which of the following during embryogenesis best explains the patient's condition? So which one didn't happen? Fast answers, please. Okay. Now, over here, let me talk about this. I'll talk about this in the reproductive system, but let me just talk to you guys about this. First and foremost, every human being is at first born a female. Okay, every human being is born as a female. Then males have a Y chromosome. Y chromosome have a gene called SRY gene. SRY gene causes the development of the male secondary sexual characteristics. How do they do this? They basically cause over here. What they do is that they cause the production of a factor which prevents the development of the Mullerian ducts. And the Mullerian ducts are responsible for the formation of the female secondary sexual characteristics. So that thing that they produce, that's called Mullerian inhibiting factor. So that's that. So over here, E is not the correct answer. The answer is this one. Okay. We'll talk about this in details in reproductive system. Are we clear? Can we move on to the next question? Yes or no? 2 hours after undergoing open cholecystectomy, okay, she develops this. She has SLE. The abdomen is not tender. Her serum cortisol are decreased. Which of the following will you find? Okay, this is an easy one. Which one of this is the correct answer? Oh, look, over here, you guys made the same mistake again. What is this patient suffering from? The patient's presentation after surgery shows chronic corticosteroid use. If we use chronic corticosteroid for a long period of time, this will decrease ACTH, right? If ACTH is decreased, which one will be affected, aldosterone or cortisol? The answer is exactly. So the answer is over here that cortisol will be more affected by that aldosterone will not be affected. And over here, adrenal insufficiency will relate to the corticosteroid use. And patients will get hyponatremia without getting hyperkalemia. So basically what they're trying to tell you is since the patient's potassium level will be actually normal because the potassium is actually regulated by the angiotensin system, not the ACTH system. So that's why aldosterone will not be affected. So keep that in mind, ACTH. Okay, one more time, I told you guys will receive questions about this. So if someone is taking steroids for a long period of time, their ACTH will decrease. And if ACTH is decreased, then cortisol is affected, not aldosterone. So in these patients of secondary and tertiary adrenal insufficiency, aldosterone level will remain normal. As a result, potassium will also remain normal. Okay, what will be affected is the sodium level. Are we clear, everyone? Yes or no? 42-year-old woman comes to the physician for a routine health maintenance examination. The patient's change in appetite is most likely mediated by which of the following? Fast answers, please. Okay, look at the patient's height, the patient's weight, and the increase in BMI. Okay, look, over here, this was a difficult question, I know, because we haven't really talked about this in detail, but this patient is not suffering from acromegaly because look at the height and the weight of the patient, everything is normal. Look at the BMI, that's also normal. The patient doesn't have any signs, symptoms of hypertension and anything else. So A is not the correct answer. C is also not the correct answer over here. Decreased hypothalamic neuropeptide Y basically stands for the fact that you have increased amount of leptin production. So this patient, for some reason, the only problem that she has is that she has decreased appetite. So this is directly correlated to why will a person have decreased appetite all of a sudden for no reason. If there is no other reason of acromegaly, thyroid problems, or anything else, if they're talking about decreased appetite, then that must mean that there is increased satiety. And if we have to talk about a hormone that causes increased satiety, that is leptin. Okay, so there's increased leptin production. Leptin is obviously a neuropeptide, right? So that's why this is the correct answer. Are we clear? Yes or no? Okay, why aren't we clear? Leptin is leptin. There's increased leptin production. This increased amount of leptin will go to the hypothalamus, and they need to be carried to the hypothalamus with the help of neuropeptides. Her BMI had been previously stable. Yes, although she does have an increased BMI, but she doesn't have an increased appetite. So the thing is, you want to focus on the BMI, that's okay. But the thing is, the Main thing you have to focus on over here is that the patient has decreased appetite. If the BMI increased from 24 all the way to more than 30, all of a sudden, if the patient became obese, right? For example, the patient used to be 24, now all of a sudden the patient is more than 30, and that's something to be worried about. If the patient's BMI increases from 24 to 27, that's still close to a normal range, so that's still okay. So over here, the patient, this is trying to make you understand, okay? What they're trying to make you understand with this BMI is that the patient doesn't have any other sort of problems such as hypothyroid or anything else for which there's a slight increase in BMI, not excessive increase in BMI. Another thing is leptin. Whenever it crosses the hypothalamus, it uses up the neuropeptides. So as a result, whenever leptin increases, neuropeptide decreases. So that's why your correct answer for this one is decreased hypothalamic neuropeptide. Are we clear for this one? Yes or no? Everyone, can I move forward? 35-year-old man comes for evaluation of neck mass hoarseness. Calcitonin is elevated. The nodule is composed or embryologically derived from which of the following? Okay, we haven't discussed this, so if you cannot answer this, that's okay. The answer for this one is the lateral endodermal amylase. We'll talk about this in details. So the thing with this one is, yes, very good, Dr. S, if that's what you chose. This is an extremely difficult question. Over here, the lateral endodermal thyroid amylase, or the ultimo, are actually developed from the ultimobranchial bodies. I'll talk about the ultimobranchial bodies and everything else when I talk about embryology. Right now, I'll move forward. But just to let you know, the answer for this one is C. Okay, talk about this in details, not right now. Next one is a 21-year-old woman comes to the physician because of hair loss. Okay. She is 162 centimeter, this and that. Okay, physical examination of scattered pustules. Okay, very easy question. Which one of this is the correct answer? Repeated question, yes. The answer for this one is theca interna cells. Okay, PCOS. So I'm glad you guys understood this. This is a PCOS. PCOS are responsible for the secretion of cells of theca interna. Theca interna are cells inside the ovaries. So since we have polycystic ovaries, we have excessive secretion of hormones from the ovaries, especially male androgenic hormones. Next one is a 48-year-old woman comes to the physician for a follow-up examination. She has a history of type 2 diabetes. Okay, her hemoglobin A1C is 8. Now flozin is added. The patient is at risk of developing which of the following? This is easy. We talked about this today. Flozins. Very good. Okay, vaginal candidiasis. Very good. Next one. 31-year-old woman, my apologies. 31-year-old woman comes to the physician because she's trying to conceive. Increase in levels of which of the following is the best indicator that ovulation has occurred? Okay. What you're confusing this with is you're confusing this with LH surge. LH surge is something else, but progesterone is the one. Right? Because towards the end of the menstrual cycle, we have a peak in estrogen, and we have a peak in estrogen, which causes ovulation with the help of LH surge. But then the corpus luteum will produce your progesterone. As we know that LH surge is responsible. For example, estrogen keeps on rising up to a point where we have a positive feedback mechanism called an LH surge. LH causes the release of the ovum from the ovaries, which gets released. To maintain the integrity of the ovulation and to maintain the integrity of this one, we need progesterone. So always remember this. If we have to measure something to see if the female is undergoing ovulation or not, we check for the progesterone level, not the LH level. LH level can give you a false positive result of ovulation. Okay. Are we clear, everyone? Yes or no? Okay. Very good. Did you guys enjoy the questions? Understand the questions at least? Yes, can you repeat? Yes, LH surge is, we do not use luteinizing hormone for seeing the level of ovulation. We use them to, if we measure LH surge, we can have a false positive or a false negative result. So to make sure we choose the correct hormone for ovulation, we choose the progesterone level. Okay, choose to measure the progesterone level. Okay, now next question is, how many of you guys have gotten 10 out of 20 at least right answers? Anyone? Anyone? 10 out of 20, 14, very good. 12, very good. 11, 16, very good. Okay, thank you so much. 16 is a very good number. So if you have received anything more than 10, then good job. Okay. If you have received anything less than 10, then please revise. 14, thank you so much. Amazing, amazing number. Very good, very good job. 14 out of 20, very good. Okay, the pass mark in the USMLE is 60% or a bit higher, though I would say 60% of 20 is 12, so 12 out of 20. So you guys are doing good, especially if this is your first time studying step 1, then this is an amazing result. So congratulations. So with that being said, thank you so much for joining the lecture for today. Tomorrow, the lectures will begin at 9:30 a.m. Please come to the class well prepared because tomorrow is an exam day. Okay, tomorrow we will have an exam of 40 questions for 1 hour. As soon as we're done with the exam, the class will end. So tomorrow will be a shorter class since tomorrow is Friday. In the meantime, in the first half an hour, we will discuss if you guys have any other further questions. Are you guys going to go through the first state today? Yes or no? For endocrinology? Since you guys have questions, yes, very good. So when you guys go through the first state today, obviously there might come a point where you can come up with 1 or 2 questions from endocrinology, which you do not understand, or 1 or 2 concepts. Yes? Isn't there a possibility? The answer is yes, right? So in the first half an hour, we will talk about different sorts of confusions or questions which you guys have from endocrinology. I'll explain everything. I'll explain all the concepts. Then I'll start the exam. So please try to make it to the class by 9:30 a.m. For the first half an hour, we'll talk about the different confusions and concepts if you guys have any. And then at 10, we will begin our exam. Okay, at 10 a.m., we will begin our exam. This doesn't mean that you'll come to the class at 10 a.m. Okay, so this means that you'll come to the class at 9:30. Okay, so that's that. Okay, so that's all for today. Thank you so much. Students who have sent me emails regarding their subscription, do not worry, your spots are there. Okay, so tomorrow we'll talk about the modes and methods of your transaction, which you can complete in the weekend. And on Monday, we will begin subscribed lectures only. The free lectures will end tomorrow. So thank you so much for joining the lectures. Hope you guys have a great Thursday. If you guys have questions, send us an email. Please read the text thoroughly. And that's that. Okay. So with that being said, hope you guys have a great day one more time. I'll take my leave. Okay, bye-bye. See you tomorrow. And best of luck.